Distinguished speakers, ladies and gentlemen, good afternoon. I'm delighted to welcome you on the 5th plenary session about urban healthcare systems in cities, access, services, and quality. The session will be chaired by Professor Mark Rosenberg, Professor of Geography in the Department of Geography and Planning and Professor in the Department of Public Health Sciences at Queen's University in Kingston, Ontario, Canada. Please give a warm welcome to Professor Mark Rosenberg. Joining him in this session will be Professor Pedro Pita Barros, Professor at Novo School of Business and Economics, Portugal. Please give a warm welcome to Professor Pedro Pita Barros. Mr. Steffen Nielsen, Director of Cities Changing Diabetes at Novo Nordisk, Denmark. Please give a warm welcome to Mr. Steffen Nielsen. And next, Dr. Easmon Otupiri, a senior lecturer at University of Science and Technology in Kumasi, Ghana. Please give a warm welcome to Dr. Easmon Otupiri. I wish you were productive.
Well, thank you very much, everyone. It's a great pleasure to moderate this session. We're going to try and ask each of the speakers to only speak for about 20 minutes so that we have a good amount of time for discussion between the audience and this most distinguished panel. So I'm going to start with Professor Barros. Ouch. Ooh.
Okay, thank you for the nice introduction. And thank you for you being here. I don't see much with the lights on me, so I guess that there are 5,000 people out there. So thank you for coming, and thank you for the kind invitation to Paula. Well, I'm an economist, and so when I was given this title for the panel, I decided to think, what can an economist bring to the discussion about healthcare in cities, access, services, and quality? Of course, access is always something that we care in economics, and putting up with equity, I thought, okay, what can an economist do that may be interesting for people interested on these issues? So I decided to think, what will be my questions to bring to this session? And of course, one thing comes immediately about equity in healthcare access in urban areas. So how does it change the access across urban areas in terms of equity? So we can talk about equity within urban areas according to socioeconomic conditions, and you can talk about across different areas, how does it differ? How much does it differ? And what I'm going to look more carefully is about the socioeconomic gradient in access to healthcare. That is, we know that we have the socioeconomic gradient index in healthcare access in general. But how much does it differ across areas? That's what I'm going to look here. But I'm also looking on healthcare access in a slightly different way, looking on foregone care and on the socioeconomic gradient. So what happens when people don't have the care, don't have the access, and don't have the care they should be done? And look on the type of service that's going on. Okay? So how do I plan to discuss this small set of issues that I put up there? First, I'm going to use a 2017 data set that we collected in our research group that looks on access to healthcare. It's on Portugal, and it has a differentiation between areas of living. So this is what we call the habitats, and it has small areas up to 10,000 people, what we call medium areas between 10,000 and 100,000, and more than 100,000, the large cities that are included here. And so, of course, there are alternatives to look on this, like on regions, and I'm going to see a little bit about it, playing a small role, but basically I'm going to concentrate on these areas, which I thought will be closer to the interests of people about thinking these urban areas. Unfortunately, I don't have a characterization of each of the areas to include, so it's going to be only on the access for people coming from those areas. Okay? So how I'm going to measure access in this case? I'm going to look on people that declare that they foregone care due to financial costs. And financial costs associated with three types of services: buying pharmaceutical products that have been prescribed, going to visit to a doctor, not going because of financial constraints, or missing appointments to transport costs and the cost that it entails. And also then I will look on the decision to look for care when people are sick, how much do they differ, and then look on the type of service selected when they are feeling sick and opt for looking for care. So what is the initial contact that people do? How does it differ across areas and with socioeconomic gradient? There are a couple of things that I'm not going to solve here, so it's already a warning label. My problem here will be to differentiate background conditions about what I call the demand side effects, which is different need for care for different people, and supply side effects, which is the ability to satisfy demand by making available human resources and equipment, especially from a national health service. Within the 15 minutes that we are supposed to take here, I don't have the time to explain in detail the Portuguese National Health Service and how things are deployed. We can defer that to the discussion if you want to know details about it. But my main concern here will be, does the NHS, in a sense, does a good job in making access more or less equal for people living in different habitats? Okay? So the sample, it's not very large, 1,200,000 people. They are representative of continental Portugal population, so we don't have the islands. They are only for people aged 15 or more. We have 7 regions that were created in the certification process, and the data were collected by a specialized company this year between February and March. And basically, we don't ask income to people because people usually don't like to talk about their income, and in the past, we had problems with this variable, so we cross education and professional occupation or previous professional occupation for retired people to get the socioeconomic status of people, and that's going to be the basis for the socioeconomic gradient. So, but basically here are the broad regions, and then inside these regions we're going to have those habitats of number of people. So this is the first set of things that we have on the data. So this is the number. So from A to E is the socioeconomic groups. A is the wealthier group. E is the poor group in a sense. This is how they are distributed between the 3 types of habitats, so that you get the feeling of how the data looks. So we have a lot of people in the last to bottom group, on the D group, and we have a very small number of people on the wealthier one, which is high education and occupations that will give you which have a relatively high wage. Okay? So it just gives you an idea of what the data looks like, because it's going to be needed to interpret what we get later on. So my first thing on here was to say, okay, let's look on the economic gradient on the simplest way. Okay? And the thing was to say, okay, so let's think about people not buying pharmaceutical products. So people declared they were prescribed something and they didn't decide and decided not to buy it because of financial constraints. So there's a net access. If there is a socioeconomic gradient, you expect that people in the lower income groups or lower socioeconomic groups will have a higher number of people reporting not buying than in the highest socioeconomic groups, and that's precisely what we get. So that's not a surprise. What may be surprising or not is that basically the 3 lines for the 3 groups, according to the habitat, is basically the same. So it doesn't matter whether you are locating in a small or a large region. And that actually makes sense, right? Because there's nothing particular on buying pharmaceuticals that has to do with the location where we are. So we feel comfortable with this. The one that we could find something more different would be if you have a visit to the doctor, right? When people have to move to see a doctor. And basically we have the same socioeconomic gradient, more difference between areas, but actually the differences that we get are not too different from each other. Okay? And so here it may not seem, but there is when we put this into a more rigorous statistical model than just having the lines, we actually have enough variation to say that the 3 lines are basically the same. So visiting a doctor and missing appointments with a doctor because of financial constraints is not connected to where people live. We also do this for transportation costs to see whether it plays a role. It does not. Okay? So we have a socioeconomic gradient, but actually it's not different from one area to the other. We may want to compare for the different groups how do they perform, and so we can just put here as an example for people that live in small towns, how do they differ on the 3 topics that we are looking at, buying pharmaceuticals, the gray bar, visits to the doctor, the orange bar, and the blue bar is buying by pharmaceuticals. And we see that basically the pattern is the same in the 3 types of service. So this gives a hint that maybe that's not much much going on this logic of habitats driving anything any different on these equity aspects of the socioeconomic gradient. So we decided to do a probit analysis, so just put some more statistics into it and have control variables to see if we clean up these things by demographic issues like age and gender, by the socioeconomic status variable, by the status of to employment, smoker, chronic patient, and the region versus the size of the habitat. And we put region as well because it may affect how services are deployed, not just on the size of the place. Okay? And this is just to make this presentation more scientific. Everything that has a coefficient is automatically more scientific, right? So this becomes a scientific presentation. It's not truly scientific because I don't have 6 digits after the comma, only 3, but it's okay, fits within the slide. Well, here probably the more important part that I want you to take from the table is that I put here only the variables that were becoming statistically significant in the process. And the point is that you see the socioeconomic gradient, the social C, D, and D, which are the classes, but you see the regions, which have to do with the organization of services, but we don't see here in this set of variables the habitat variables, where it's the small region, small town, a medium town, or a large town. And basically, the system as it is cleaned up that part. Does not make a difference in these access stories, where do you live? And in particular, the socioeconomic gradient is no different between areas. So being rich is better, but is no better in a small town or in a large town. Okay? So this is remark 1. Socioeconomic gradient exists, but is independent of the size of the habitat. Doesn't matter that part. Then we look on the probability of barrier to access to be active is not associated with the size of urban area in that component. So we have the 2 implications. Now let me look on the different question that people usually don't look on. That's not common in access stories. That is what people do when they feel sick. Okay? And what would they decide to do? And they can decide to look for treatment, or they can decide to look for something else, which could be waiting, could be self-medication. And here I wanted to do the same thing, and what is the probability of looking for help according also to the region where we live, or the habitat where we live, small, medium, or large towns. And again, we have put only here the things that seem to matter. And apparently what makes more difference for looking for care is that people have a chronic condition, they look more for care when they feel sick, which is something that we could expect. But first, we have finally here that social groups matters for the socioeconomic part, but also the medium area. So people living in medium-sized towns seem to look more for care when they feel sick. I don't have an explanation for this at the moment. I think we can conjecture several ideas, but it is curious to see that something that didn't show up in the socioeconomic gradient per se, in the prescribing pharmaceuticals and so on, does seem to showing up here. Could be a statistical anomaly as well. We don't have a very large sample, but it's something to think about. Does the deployment of services have something to do with this difference or not? So this is the remark 2. And the second point about it is that if you look on the marginal effect, which is what is a change in the probability of looking for care if you live in a medium-sized town, is almost 13 points higher, the percentage points higher than if you live in a small or in a large town. So that's the economic. So even from a magnitude point of view, it seems to be a reasonable value. Okay? But that was not enough. That's why I thought, okay, maybe what's going on here? Let's think what else could be relevant in these decisions. And we decided to look on, and we asked things about people about how much do they spend when they go to healthcare. And when we asked people how much did they spend the last time they went to a hospital visit, emergency or not, and what do they spend when they went last time to a primary care. Primary care is closer. Primary care has a smaller user charge than the hospitals have. We have lots of people exempted that don't pay in each of them. You have transport costs that are borne by the people, which we don't know who they are. Primary care network supposedly is closer to people, should entail a lower cost. Now, what we find is that the cost of a visit, the out-of-pocket that each person spends, is not very different according to the area where they come from. So people still living in small areas have basically the same expenditures, including transport costs, that have people that live in larger areas. And so it could be a signal saying that the deployment of resources is actually getting some proximity, even of hospitals, to people. Curiously, in primary care, the people that live in smaller areas have actually a lower cost, overall cost, than people in large areas, which makes us think, what's going on? Shouldn't we have economies of scale here in some sense? Actually, since we put here all the costs that people had, including user fees, transport costs, pharmaceuticals prescribed, and other costs, what is driving most of these cost differences is actually pharmaceuticals prescription. Okay? And so the differences seem to be connected to the pattern of prescription in those areas. So this is my almost last point in terms of data, and it asks people, when you felt sick, what did you do? Okay? Where did you end? We allow people to signal more than one thing. They can try several things at the same time. And basically, what we have in here is the possibilities of people going to unscheduled primary care visits, going to emergency department in a public hospital, so unschedule again. You can try to book an appointment with your family doctor using programmed primary care. You can use the NHS helpline. You can go to a private doctor office, and you can go to emergency department of a private hospital, or you can ask the pharmacist, which we included because there is a discussion about what could be the role of pharmacists as a first contact to people as well. And what we find here, and then you have the blue line for the small areas, for the small habitats, you have the medium one for the medium size, and the large ones for the large things. And what comes out from this picture, it was not totally surprising, but it was larger than we expected, that people living in larger areas tend to go much more to the emergency room of the public hospital. And so when people feel sick, instead of going for the programmed activity, they actually go for the emergency department. It's good because also we don't see that in the use of the private hospitals. For using private hospitals, we see that the medium-sized areas go more often there, which in a sense makes sense. Large central hospitals with famous emergency departments are in the center of towns. They are in the large urban areas. But still, it was a little bit striking to see that gray bar so large. And so the question was, what does this tell us about the access of people? Well, it probably tells that since the cost of going to the emergency department, and cost here will be the price to be paid, but also the opportunity cost of time, and time driving there or getting transportation there, and so on, seems to be smaller in urban areas, in large urban areas, and people just react to that and use the facilities that are open more time, 24 hours a day, 7 days a week, instead of trying to have a programmed situation, which is a counterpart of the gray bar. So they seem to react somehow, even implicitly, to economic prices involved. And to check a little bit for that, we looked on what was the distance of people in time that they take to get there between the areas to get to emergency room services. And in the different areas, what we get is that, of course, there's a huge number of people that is located relatively close, around 30 minutes, 20 to 30 minutes. And then you have some people that say they live very far away, up to 4 hours. I'm not sure I would trust things more than 2 hours away from an emergency room, but people said so we kept it there. But basically we see that people in the large urban areas seem to say that they live closer in general to the emergency services, which could explain a bit why they use it so more. Okay? So that will be a relative price in economics. That would make a lot of sense for an economist to see the effect. Although I will say that personally I think that's too large of an effect. Sorry. So the time to emergency department is actually not very different between the different areas. So if you take the average value that people declare, it's actually 5 minutes difference. Does 5 minutes difference justify this gray bar up there? Seems a little bit too strong of an effect. So we think that maybe it's something else going on as well on these stories. Okay? So then my third remark, in getting close to this, is that out-of-pocket payments differ across the origin of patients from different urban areas, but the difference is small. So apparently the National Health Service in Portugal is making a good job in trying to have this equity aspect of access being independent of where people live. The only remark here is that people living in large urban areas look much more often for emergency room when they feel sick and use less family doctors. And so this is a puzzle, and my feeling at this stage is that it's not a problem of supply side, it's a problem of the demand side of how it is done. A piece of information, the OECD report on emergency rooms use across OECD countries puts Portugal as the country with the highest percentage of people going to emergency rooms. And so there's probably something here, and it seems that then the problem is not overall in the overall population, is actually concentrated in large urban areas, driving that part. And so we have to think what is driving this part here. So my final remarks as we're closing to the 20 minutes time. Well, the size of urban area where people live is not associated with access barriers. So we want to look for access barriers, we look on socioeconomic determinants, we look on whatever we want, but not exactly differentiation across areas. Equity in the sense of differences in access to healthcare with urban level are not justified. We should not be, it's not a matter of major concern, I would say. We have other things to look more across socioeconomic groups. And even the socioeconomic gradient is not different between areas, so we can treat them in policy terms in a similar way. Okay? And that's it. Thank you for your attention.
Thank you so much. As a geographer, it makes me a little bit nervous when the economists tell me that geography doesn't matter.
Well,
so we'll have to come back to this question.
Okay. Yeah.
Okay, so our next speaker is going to be Steffen Nielsen. And for those of you who don't have a program in front of you, he's the director of the city's Changing Diabetes program for Novo Nordisk from Denmark.
Thank you very much, Mr. Chairman, and thank you very much to the organizers for inviting me, and thank you very much to the city of Coimbra for hosting us this week. What a beautiful town. Before getting started with the presentation, I would like to tell you a story about a woman. Her name is ISUH. She lives in Mexico City. She's 44 years old. In Mexico City, diabetes is the leading cause of death. She works every day selling bottled gas door to door in the district where she lives, and she makes $180 a month by doing this. Her work performance is greatly affected by her poor health. 10 years ago, she was diagnosed with type 2 diabetes. But as she says, she's a happy woman, you can see. It's just another condition. She's been living with many conditions since she was a child, and as you can see, she has mobility issues. Her leg has a bandage. And actually, she's also having vision loss on both eyes, so she's greatly affected. Sometimes during the day when her blood sugar drops and she hasn't got much money left, she will buy a Coca-Cola and a chocolate bar to get her blood sugar levels up again. She knows it's not good for her, it's unhealthy. She's very aware that she should live a healthy lifestyle, but she simply can't afford it. And one of the things that worries her a lot at the moment is that she recently lost coverage from a government healthcare program, which secured her healthcare in the part of the city where she was living. So she is very worried about that. ISUH, she believes that it's the stressful life you live in a city combined with all the condition that she's facing that has caused her diabetes to evolve. So that's a firm belief of ours. And she's a real woman. Her name is not ISUH, but she's one of the more than 700 people we have interviewed for this program. So this was not made up. This is a real story, and there are many of them out there. Actually, there are more than 400 million of those stories out there. And I think in a conference like this, I know we are a lot of practitioners, academics, business people, and people from NGOs here, but we must never forget this is about real people, and that is why we are doing it. That's why what we're doing is so important. 450 million people today. We call it an emergency in slow motion, what's going on. Look at the numbers. In 2040, you can't see the number here, but I know it. It's 642 million if we believe in the numbers from the International Diabetes Federation. They come up with these numbers every second year, and every second year they have been undershooting the estimates. So 642 million people in 2040, that is actually a conservative estimate. We have to do something. 2 out of 3 people with diabetes, they live in cities as it is today. Every 6 seconds, somebody around the planet will die from diabetes. So when this session is done, 900 people will have died from diabetes. That's a lot of people. Cities, they influence the way we live, the way we work, sleep, travel, move, everything. And some of the factors that impact the way we are living, both positively and negatively, is up here on the screen. Food choices. Do we eat healthy food or do we eat not so healthy food? What type of food do we eat? Why do we eat it? That's one of the factors. Another factor is obviously which type of lifestyle we are having. Is it sedentary or is it active? Do we have time to live an active lifestyle? Work is another one. We know a lot of people have been moving from the rural areas into cities over the last 100 years. And the work in cities is very different from the work in the countryside. It's much more sitting behind a desk, sitting behind a screen. That is also a factor that impacts us. Then there's our media consumption, and I really have to change this slide. I mean, how many has a TV that looks like this? Not a lot, no. So we probably, but media consumption is actually one of the things, because we spend more and more time looking at our phones, looking at our screens, TV and so on, and less time on actually moving around. When I was a child, and that's 20 years, 30 years ago, when I had my time off, I did not watch that much TV. There was not so much to see. There was one TV channel in Denmark when I grew up. I went out and played football. It's not the same today. Then finally, transportation. How do we get around? What choices do we have? Do we go by car? Do we walk? Do we bike? Or are there other choices? So, these are some of the questions that we need to understand if we want to understand why some people become vulnerable towards developing diabetes. I come from Novo Nordisk. It's the world's largest manufacturer of insulin. We have been working with diabetes for more than 90 years. We have been innovating, so many of the newest types of insulin has been innovated by us. We've been driving leadership all those years, and we will continue to do that. But we also know that it takes much more than medicine. I think the biomedical domain is only the tip of the iceberg if we want to get to the bottom of non-communicable diseases. And that's why we initiated Cities Changing Diabetes Initiative in 2014, together with University College of London and Steno Diabetes Center. We started out with 5 cities in 2014. It was Mexico City, it was Copenhagen, Houston, Shenzhen and Shanghai. And what we do whenever we are starting up in a new city, because as you can see now there are 8 cities, and actually this slide is already old because last week a 9th city joined the program. But what we are doing whenever we are starting up in a new city is that we set up a team in the city. We are working with city leadership, both from a political level, but also on a civil servant level. We are working with local academics. It's very important that we have the local understanding of the situation in the city there. And we are working with NGOs, we're working with community organization, patient organization, and so on, and also local businesses, if that's appropriate in that particular setting. If you take a slide, I mean, 9 cities now, close to 75 million citizens. We have already initiated 21 actions, and we have more than 100 local partners involved in the program. And what we're doing in each of the cities is we're following a program we call Map, Share, and Act. So in each of the cities, we are mapping the situation, both through quantitative methodologies and qualitative methodologies. In a city, we do what we call a rule of halves. That's a quantitative methodology. How many in here knows the rule of halves? Not a lot, or maybe I have light in my face. It's a methodology where you're looking at all the people with diabetes. How many of these have been diagnosed? Of those being diagnosed, how many are receiving treatment. Of those receiving treatment, how many are achieving their treatment targets, and finally, of those achieving their treatment targets, how many are achieving or are living a life free of complications. And the rule of thumb says that roughly 50% drops out every time you ask one of those questions. That's why it's called rule of halves. It's a very nice way of looking at it from a quantitative perspective to see where are the gaps in a particular city. And if I take my hometown of Copenhagen, 75% of people with diabetes, they are diagnosed. So diagnosis rate is not the issue in Copenhagen. But we see that only 40% of those receiving treatment, they actually achieve their treatment targets. So there is a gap there. That's one example. In Shenzhen, out in China, it's completely different. They have very low diagnosis rates, so they have a different issue. The qualitative methodology is a vulnerability assessment that was developed by University College of London, and they go out to each of the cities and train local field workers. That was what they did for the first 5 cities. And there we interviewed those 740 people, just like ISUH, to find out why some are vulnerable and others are not. And they came up with 8 very distinct social and cultural factors. And those factors we have boiled down into another methodology that we can roll out anywhere in the world, basically. So in a month's time, we will actually launch this new methodology, which is being piloted up in Vancouver in Canada at the moment, and it will be given free for everybody to use. Then the second part of the Map Share Act is sharing. So sharing within the cities, but also across cities. It's sharing in traditional media, in scientific publication. It's me traveling around giving presentations like this, but it's also sharing across the different members. So we have set up knowledge networks, both for academics and practitioners. We are setting up a network for urban planners, for community action researchers, and so on. So sharing is on many, many levels. So it's kind of a prerequisite if they want to join that they are willing to share. There are no secret in this program. It is not being trademarked or anything. We don't have any IP. That is not our point. We actually want to give this free to the world. And finally, the last step, that's acting or action. I think it's quite trivial if we are doing the research and going out and showing there's a problem if we are not acting. We have to act in partnerships, and that is why this is a big global partnership program. And in each of the cities, the working groups have to come up with an action plan. They have to come up with how do we appropriately address the issues we found out in our city, and how are we going to fund it? Because it's very important that we think in sustainability from the beginning. I think for too long, companies like mine, we have done research and we have been putting the numbers on the table of the decision makers and say, you have a problem, do something about it. That is not the right way to do it. I think another way we've been doing is also coming in with a bag of money, and then things were happening for a period of time until the bag disappeared. That is not the right way of doing it either. I think it's important that we think sustainability in from the beginning, so we are ensuring that the good things that we are doing, they will sustain, and we will also learn from the things that are not working, and we are sharing that as well. That is equally important. To make it a bit more concrete, I would like to talk about where action is taking place. And what we have done is that we have condensed the learning that we have done in order to find action arenas. And we found out that there are 4 action arenas that are working. I'm not saying that this list is exhaustive. I'm quite sure that within a short period of time we will have a 5th action arena called food systems. But right now we have seen actions of those 21 actions I just talked about within these 4 action arenas. So that could be health promoting policy, urban planning, community involvement in health, and health system strengthening. And I have some pictures with examples of the different activities that are going on. I mean, the first one up in the corner, that is the Copenhagen health mayor, the lady in the blue dress signing the memorandum of understanding. And in the back, actually, the guy with the mustache is the Minister of Health from Mexico City. So that's a way of, you can say, knowledge sharing from the beginning. In Copenhagen, they have changed the health strategy. It is called Enjoy Your Life Copenhagener. One of the action plans in the new health strategy is a diabetes plan. And a specific diabetes prevention center has been opened, so with a specific focus on preventing diabetes, but also by treating the ones who have recently been diagnosed, because we know that's a period of time where you're especially vulnerable. So there's a place where people, they can come, they can train, they can learn how to cook healthy meals, but they could also meet mentors and peers at that place. So that's very positive. And this new center in Copenhagen is entirely funded through the municipality, but it is co-run by the Danish Diabetes Association, so the patient association. Very, very nice example. The next picture is a bike sharing scheme in Mexico City. I cannot claim any honor for that. That was happening before. But what we have done is that we have, together with C40, the climate leadership group for mayors, we have developed a way of evaluating benefits of climate investments. So when they did this bike share scheme in Mexico City, we have evaluated that, and in the section coming after this session, I can do some advertising. I will talk a bit about that. In Italy, they are working with preventing obesity and diabetes through physical activities with kids. So they are very much involved together with the Italian Athletics Organization and the Italian Olympic Committee. Very nice. In the middle here, you will see a Mexican case. It's called Médico en tu casa. I'm not a Spanish expert, but I've been told it means that the doctor is in your home. It was a maternal health program and still is, where doctors are going into people's homes to find especially young pregnant women, because they were very vulnerable, often not seeking health care because of affordability issues. Since they found out that there was also a big group of vulnerable people in diabetes, they decided to include diabetes in this program, and this has now become a policy in Mexico City. So another very nice example. And then the final example is also from Copenhagen. One of the findings in vulnerability assessment was that there was a group of vulnerable people in Copenhagen that was missed. And that was lonely men above the age of 45, often unemployed. They are not seeking help from the healthcare system. They are not seeking help from the municipality. They kind of distrust it. They will seek their social circles at bars and other places where health behavior is probably not the best. So what they actually did was that they invented what they call food for men. And basically it's a food club. These men, they are meeting up once a week, cooking together, having a good time. And in that way, and it's a very low cost and very cost effective intervention, in that way you can stimulate a better confidence within these men. You can give them social circles that they were missing, and also teach them about healthy food. So all in all, a very good intervention. I forgot to speak about Houston before, and one of the findings in the Houston, and I think that's an important one, also speaking to all these things that are impacting a life in the city. In Houston, they had an assumption before they did the vulnerability assessment about who the vulnerable people would be. They thought it would be the elderly. Makes sense. Aging on its own is a risk factor for developing type 2 diabetes. They thought it would be the poor. Makes also sense. Also makes sense. And they thought it would be immigrants, especially immigrants from Mexico. Also makes sense. But the biggest group of vulnerable people in Houston was actually probably the people you see in the photo. It was middle class and upper middle class. People who had enough money. They had healthcare insurance, they had education, they had knowledge, had it all, except one thing. Anybody would guess what that thing they were missing was? No, I can't hear. No, the thing they were missing was time. So this concept of time poverty. They did not have time enough during that day to do the things that was a good health behavior. Means physical exercise. Did they spend 30 minutes, 1 hour a day being active? Did they do the grocery shopping? Did they buy the things that means that they could have healthy meals? How many in here are time poor? I see a few. That is really, from our study in Houston, that was the hidden gem there. Not that it was not important that we found out that the elderly, they were vulnerable, or the immigrants, or the poor, but we knew that in advance. But these findings we see everywhere that we did not expect. These are the ones that are particularly important because that's where we are finding gaps and where we can do action in the future. And before I'm closing off here, I would say, I mean, as I said, we are open about everything that we are doing. We are giving our research methodologies free. So watch this space here, and then in 1 month's time, we are having our second Cities Changing Diabetes Summit. It will take place in Houston, and during that summit, we will launch what we call the Urban Diabetes Toolbox, where all of our learnings so far in the first 3 years will be given away for free, so everybody can use them around the world. Thank you very much.
Thank you, Steffen. I think the notion of public-private partnerships is always a fascinating one and perhaps sometimes a controversial one, and perhaps we can come back and discuss that after our final speaker, Easmon Otupiri. And I'm particularly pleased that Easmon is here because he stepped in at the last moment. And, you know, he may be a substitute, but he's the best substitute we might have found, so please.
Thank you, Mr. Chair. Nice. Good afternoon, ladies and gentlemen. It's a great privilege to be here with you today, and on behalf of my colleagues, I want to say a big thank you to the audience for coming to listen to us. As the chair said, I was called in at the last minute to take the place of one of our speakers who couldn't make it. But you know what? In football, when you get a late call-up to your national team and you agree to come and play, then the next time, the coach is likely to give you an early call-up. So I accepted to come, hoping that the coach will call me early next time. Since we are talking about urban healthcare systems in cities, referring to access, services, and quality, I will be talking about an initiative in Ghana that primarily was put together to serve this purpose. Unfortunately, due to the late call-up, I don't have slides, as beautiful slides as my colleagues to show you, but I hope you will not fall asleep. The idea is to reach everyone with basic package of essential health services, and that no one should be left behind. But as far as we are concerned, we have been implementing this system for some time. A lot of countries have come over, taken the core principle, gone home, made it context specific, have implemented it, and are getting great results. Are we getting great results in Ghana? I don't know, but probably we will find out. Ghana started using this basic healthcare principle in terms of community health workers way back in 1977. And that was before Alma Ata. And we signed up to the Alma Ata thing, and we started operating the full primary healthcare system in 1980. And we have a 3-tier healthcare system. The primary level required to provide primary health care up to the district hospital, and then the secondary level, and then the tertiary level, providing more sophisticated care. The idea was to provide close to client health services and to take care of minor ailments with an emphasis on prevention and promotive services through door-to-door services. And we have had a series of 5-year medium-term health strategies since 1996, all designed to package the services better. The system or the intervention that I'm talking about is known to most of you here, and it has been labeled the CHIPS idea. CHIPS simply means not the chips we have with lunch, but it means community-based health planning and services. And we have implemented this for over 10 years. It has as the main actor, a community health officer who is supported by community health workers and a community health management team. This concept was developed after operations research at the Navrongo Health Research Center, and it was fully adopted by the country in 1999. So there's the community health officer, who basically is a community health nurse who has received additional training and is to provide basic care and then to place a lot of emphasis on promotive and preventive health services. Then there are the volunteers who mobilize the community and also undertake some health education and promotion activities. And then finally, there's the Community Health Management Board that was supposed to oversee all this and put all the pieces together. So we've been operating the system, and in 2008, a new term emerged as a result of all the confusion that was going on in the country as far as how the system should be implemented is concerned. And the term that emerged was called functional chips. And what it meant was that since most of the chips compounds or the chip areas did not have the full complement of the systems component, we should have this term functional chips for the chips areas or zones where at least there was a community health officer in operation. The community health officer was supposed to have a compound or a building that would provide both accommodation and serve as a small clinic for treating these basic conditions. As at 2015, we identified 3,175 functional zones and 1,410 functional compounds. In our country, a zone was supposed to be equivalent to an electoral area. So you can imagine the politics that come with it. The politicians are always interested in trying to demonstrate that they have brought healthcare to their locality. And therefore, they would increase the number of electoral areas just to have many more CHIPS compounds within their areas of operation. What was clear was that there was a lack of clear policy direction, and that confused local action. The changing definitions of what a standard basic care of intervention was also an issue. Additionally, the idea of one community health officer appeared to be inadequate. And so there was a debate about whether there should be 2, or there should be 4, or there should be 3. Furthermore, we were not too sure what a prototype CHIPS compound should look like. And what we realized was that instead of the CHIPS providing door-to-door service, it was becoming more and more stationary. So the communities that they were serving were more likely to come to the venue, the CHIPS compound, to receive services than the community health officer moving from door to door to provide the basic health services and the promotive and preventive services. So some of us term to label it primary medical care instead of primary health care, because the promotion and the prevention virtually disappeared. Furthermore, remember that I talked about 3 components: the health officer, the volunteers, and then the management team. There was nothing for the volunteer. The volunteers were not trained, nobody ever thought about them, and we expected them to function. And the management team, they didn't have any training either. So what were they supposed to do? And especially as far as financing was concerned, with the implementation of a national health insurance scheme in my country, the health insurance scheme was reimbursing for medical care, but not for promotion and preventive services. And so the CHIPS compound was more likely to undertake the medical care in order to earn money or reimbursement for the health from the health insurance scheme than to do the promotion and prevention that nobody ever saw. And those of us in public health, we bemoan that a lot. I remember that as a young practitioner in the early 80s, in the hospital where I was working, every day, and I mean every day, 1, 2, 3, at least 3 children would die of measles. You would be in the central block of the hospital complex, and you would hear women wailing. And as soon as you heard the wailing, you knew that a boy or a girl, a child, was dying, and it was always out of measles. So a few of us decided that no, we would go rather to the communities and undertake vaccination against measles, rather than wait for them to come for the measles vaccination. And we did this for 2 years, 3 years continuously. And the wailing disappeared. Today, the wailing doesn't come anymore. And we are even worried that our medical students will not recognize measles if they should meet one anywhere, because we don't see it anymore. But nobody ever gave us any credit. We were not recognized nationally, and the mothers and the parents didn't come to say anything. But if you gave somebody medication for malaria, and the person didn't die, or the child didn't die, you can be sure that the parent will never, ever forget that, because you saved that individual child. So the promotion and preventive components have virtually disappeared, even though they were supposed to be the bedrock of this intervention. So after a lot of debate, finally, last year, as recent as last year, the government put together policy directives in a 5-point statement that gave fairly clear directives as to what the implementation of the policy or the intervention should be. But even with this document, it's a well-written document, there are still serious gaps. The first gap is that it assumes that this intervention would work or is meant for rural areas. What about the urban areas? There's only one statement in the policy document concerning urban areas, and it reads, urban CHIPS is feasible. As simple as that. But my experience with the community health workers or the community health nurses who work in a hospital that operates the urban dimension of CHIPS is that they have huge challenges. First of all, they are not living in the communities they serve, so they are at a distance and they have to travel. Nobody reimburses them for that cost. Additionally, the peri-urban communities especially, if you go there at 5 a.m., you are unlikely to meet any man at home. They have all left home to go to look for some money to bring back home. And they come back very late. So service provision to such a mobile community or such a mobile target is extremely difficult. Finally, because they are working in an urban environment, the understanding of the community they serve is a bit different, because in the estimation of the community, the hospitals are not too far away. So they don't seem to appreciate this door-to-door implementation or this door-to-door policy. Furthermore, this new policy directive, which I say is well written, doesn't say anything about the promotive and preventive components. How do we go back to those basics? How are we going to pay for those? And how are we going to remove this concept of primary medical care and go back to primary health care? Ladies and gentlemen, thank you very much.
Well, we've had 3 very thoughtful and provocative talks, and I have lots of questions for the 3 speakers, but I'd like to open it up to the audience and give people in the audience a chance to ask the 3 speakers questions. So, it's up to you, folks. Who would like to take the microphones so that I think are going around and ask our speakers some questions?
Thank you very much. My name is Asensu Jemibi. I'm coming from Ghana, Council for Scientific and Industrial Research. And I would like to make a comment in relation to what my senior colleague from Ghana made in respect of access. And I think when he started, he said, are we getting great results? And as a layman in Ghana, I would say no. Because one, the spatial distribution of our hospitals in Kumasi makes it difficult for people to access healthcare. Everyone would want to go to Konfanochi Teaching Hospital, where all the gurus, all the specialists are, and neglecting the sub-metros. Of course, the sub-metros have, quote and unquote, less experienced people and few doctors to attend to. And to go to Konfanochi, you need to be well connected so that you can get access to the specialists at that hospital. That is one issue. And now there are no more peri-urban hospitals. They have become part of the urban hospitals. So that is the problem. And you go there, you want to access healthcare, you start in the morning and you have to spend the whole day at the hospital. You have to queue for a card, you have to queue for pharmacy, you have to queue for consultation. And people would not want to do this, but would want to just go to a pharmacy shop, buy medicine, and do self-medication. Again, you have most of the doctors at Konfanochi, as I said, so people would want to go there, creating more or less stampede, and it creates problem for access. Data collection is a big issue in our health delivery system. Data is collected manually, and if you want to get some kind of data to do analysis for policy direction, it's also a problem. And I think these are some of the things that I would want to bring to the attention of our healthcare professionals so that it can be integrated into the healthcare policy. Thank you.
Easmon, would you like to respond?
Well, I thought he was making a comment, but I agree with him. We had a dissemination for a study that we did last year that assessed the primary healthcare performance using the primary health performance, primary healthcare performance initiative framework. And one of the huge things we saw was that there's a lot of bypassing. You know, a lot of clients bypass the lower levels and go directly to the higher levels. And if you ask the client, the usual result is that, oh, I might get referred anyhow. So, but the point that I want to make is that if we will go back and place emphasis on the prevention and promotive care, all these little things can be taken care of, because the big hospitals are not meant for uncomplicated malaria, for example. That is supposed to be treated at a lower level. But because everybody has the notion that you might get referred, so why not go there directly? That is why they go there. And if we would improve the promotion and prevention, then this double-edged sword that we are getting of diabetes and other chronic infections would also come down. And then the cost of healthcare would also reduce. And then we can pay more attention to those who really need the healthcare.
Okay. Another question from the audience? Well, let me ask a couple of questions then. I'm going to start with Pedro. And I'm fascinated by your findings. Obviously, you present a very convincing case about the importance of the socioeconomic gradient and its implications for access to care. But I was wondering whether when we talk about access to care, particularly in the context of a country like Portugal, or dare I say Denmark or Canada, whether or not we miss many of the issues that are in these surveys that we do that really change access to care. So for example, whether employers by law have to give time off for people to go to work or to actually get primary care. Certainly in Canada, employers aren't obligated to do that. So these are issues that don't come up in the kinds of surveys that you're using. And I wonder what your thoughts are on that type of issue.
Oh, that's very easy. In this survey, I didn't present, but we asked that. We asked whether people were foregoing care because of afraid of working conditions, whether they would have it. And it didn't matter. That was not an issue for people, at least for the ones surveyed here in Portugal. That was not an issue. People have the right to go and bring a paper, but we asked whether they would have problems at work, whether they will look bad at work, and whether they will lose a one-day wage or something of that sort. And those considerations didn't matter. I didn't present here, but I will be glad to send the results to anyone that wants them. Just email me and we'll get to it. And so in that sense, does not matter. I think that but they are right in the sense that there are a lot of things that we should ask more about how people decide on these access stories. And that's precisely what we want to look on this survey. And curiously, we wanted to check whether the usual presumption that geography matters a lot, whether it has been actually countervailed by the deployment of the health system. And I didn't have time to go through here, but Portugal has a strong network of primary care. There are several works at the European level that makes comparisons. There is one by Dion Kringos and the people at Nivel in the Netherlands. They have the surveys on this, and they show that Portugal is one of the ones with the strongest primary care. And basically, we want to check whether that primary care will be reflected in this first decision of access to people. And basically, it seems to go along on the direction saying, yes, geography may matter, but it's somehow countervailed on these equity types of stories by the deployment of the services. The only thing that does not conform with that story is the use of the emergency services in large urban areas where you have the strong hospitals, which goes to the comment that we just had about the role of the hospitals in creating an umbrella in a reputation that is so strong that actually brings everyone to there. And actually the challenge for health systems that have these strong hospitals is how to bring the reputation umbrella of the hospitals to the primary care and to these prevention stories. Actually, the comment in your presentation I was thinking, what would happen if one of these strong hospitals actually created a brand that people from primary care will go and say, we have the certification by this most important hospital saying that we are doing promotion according to the guidelines. And that will bring the umbrella of the hospital reputation to the primary care. And in a sense, our emergency department stories are probably associated also with these umbrella stories of large hospital units actually sucking up the demand for nearby people. And I think that's common to those presentations. Money. They have the money, but they could use the umbrella to help primary care as well. And I think that's the point. On the prevention issue, well, now we are commenting on another one, sorry. But on the prevention part, that's always a puzzle, also for us economists, why everyone talks about prevention and health promotion, and then we don't see it working in practice because of the payment issue. I think the basic issue, you touched it very well, is that we don't often see what are the results immediately in a way that is directly linked to the payments. Yeah. And your example of measles is actually perfect. Next time I will talk about prevention, I will borrow your example. But the question is how to pay for something that is invisible and it's up later on time. I think that's a big challenge. Sorry, Mark, for disturbing the session.
No, that's perfect.
I would actually love to chip in as well.
Yeah, please do.
One of the 21 actions I put up here was an action from Tianjin in China where they have a huge issue of patients showing up at the hospital because they do not trust in the primary care physicians. So what they did was that they trained 300 what they call grassroots physicians. So they actually are the good physicians going out and teaching just like you're suggesting. So
this umbrella story.
Exactly.
Steffen, let me ask you a question. What you described to us is a remarkable partnership between a large private international corporation and various public entities literally around the world. What was the greatest challenge from your perspective in organizing this public-private partnership?
I think the answer can be split in two. There's an internal and an external challenge. I think the external challenge is most interesting for this audience at least, but I'll answer both. The external challenge we've seen in many of the cities where we came out, and in the beginning, when you're not known, then it's kind of a sales effort. You have to go out and say, would you like to be part of this partnership? We saw it in Houston, we saw it in Copenhagen, where the local authorities were saying, you're a pharmaceutical company. I think I know why you are here. You probably want to promote your products. So we said, no, that's actually not what this is about. We would actually like to work with you on identifying vulnerability and do something about it in your community. They said, okay, that's fine. If you truly mean that, then we should have a prevention program. And we said, that's fine. Because our mission, and it's been that mission since 1923 when we were started, was that we want to prevent, treat, and ultimately cure diabetes. And here we're talking about type 1 diabetes, I assume. And we truly mean that. If somebody is to find that cure, it has to be us, because we've been in there for so long. You can say, I mean, the first 1.5 years in any of the cities we've been working has been a trust-building phase. And another of the, you can say, the barriers we are having is it takes quite a long time. And I have some interesting anecdotes because as a pharmaceutical company, we are usually working in a very regulated area, and we are very organized, and everything is in strict plans. And this program is not like that. And we're working with city governments, we are working with academics, and their pace is just very different from ours. So I have an example from Houston where the professor we are working with, he says, "Whoa, this is so fast. I've never been in a public health program where it went so fast." And it's interesting because when I'm at home at the business, and that's the second challenge to say, when is something happening? When is something happening? That's kind of this impatience. So that's one of the barriers at home. And another barrier at home is even colleagues of mine has a hard time seeing why on earth should we do prevention programs. But I think we should do that, first of all, because it's a moral obligation, obviously, but also, and that's to be completely transparent, it's also enlightened self-interest. If we're going from 400 million people with diabetes to 600 or 700 or how many million people it will be 25 years from now, I mean, that's a human tragedy, but it's also a tragedy for the healthcare system. They will go broke and there will be no money left for innovative treatments that we are producing.
Okay. Questions or comments from the audience? No?
I have one.
Please.
to Steve. Actually, I wonder what will be the next step of this partnership. So in a sense, you're deploying an experiment and seeing if things works. How do we ensure that after its time is over, that things don't fall apart?
Yeah.
So how are you going to cement the partnership for the future? What was the way it was done?
I think there are a couple of ways, because I'm thinking a lot about that at the moment. First of all, we don't have a back end. And I think that's important. We're both economists. We know if there is an end, and this is, I mean, this is game theory. If there is an end, then something bad will happen before the end, obviously. So, but we don't have an end as it is right now. I have a budget every year, and at a point in time, I will probably not have it anymore. And before that time, it's important for me that I build sustainability in this program. I think we will be hit by a hammer, a very hard hammer, if we are pulling out at a time where it's not sustainable. Then it is our responsibility. So I think it's important that we build these sustainability plans both in the cities and across. And this sounds very fluffy, so maybe I should be a bit more concrete. It will require that we are building these knowledge networks. So that we are having an academic knowledge network that is not driven by Novo Nordisk, but is driven by an academic in the group who is willing to drive it all, even though we are not there anymore. Or if we are having the Community Action Research Network, it's driven by Steno Diabetes Center, and it will most likely continue. Or the urban planning network that we are running together with C40. I mean, they will be doing that anyway. They are having, I mean, they're working with cities and urban planning anyway. So building the sustainability in the plan, so it's not driven by Novo Nordisk or any of the other partners, but actually been made ready for a future where it can continue no matter who's in charge.
Easmon, did you?
I will talk to him afterwards.
The other question I want to ask all three of you, or maybe I hope all three of you will have a response. What fascinates me always when we talk about access to care, and when we differentiate the different levels of the healthcare systems in our countries, is how these systems work during the daytime hours and how these systems work during the nighttime hours. And I mean, certainly in the province where I live in Canada, the provincial government has tried all sorts of incentives to convince particularly the primary care physicians to work evening hours, like to keep their clinics open at night, and not very successfully. And so one of the reasons the emergency services are so well used, particularly in the nighttime hours, is because, in fact, they're the only alternative. So, Pedro, what are your thoughts on that issue? What did the data in Portugal tell you?
Well, there's certainly the use of the emergency services during nighttime more than daytime. Though what we have seen in the last years, say since 2013, that we've been following with these sort of surveys, is that people have actually moving to a more organized use of the system. It helped that we had several changes in primary care, introducing in 2005 more flexible ways of work in the system, so they have longer working hours and working differently, and that seemed to help. But most of all, I think that what people need to have in place is, when they feel sick, the confidence that everything will be solved in a single place. And I think that's true for daytime and nighttime. And probably one of the challenges for the primary care services is actually they can do some of the basic testing, say some blood tests, some x-rays, so that avoid emergency use and have somewhat longer hours. And convincing doctors to do that without the extra pay is, of course, difficult. Now, the flexible working models allow for that in a sense. And they are paid in a mix of capitation by list and not by activity, so that helps them try to keep people to keep people happy. But of course, nighttime will always be different than the daytime. The question is whether new ways of contacting the NHS could be working here. And in that sense, I had some years ago the idea that the NHS helpline could be a help for this. People could phone or could check on the web before going, but apparently we are not yet there. And I think we are still very far from it. And actually it's amazing how just a very small number of people actually phoned the NHS helpline, giving that if you phone through the National Health Service helpline, you can actually get to the services if they recommend without paying the user charge. So I think that we need to understand better why people behave the way they behave. And I think that one of the things that I've learned over the years that we, economists and probably other professions that work with health services, tend to be too much assertive on what we think people do. And actually they are surprising on the ways they do what they do. And we certainly miss some aspects. And so the daytime, nighttime, I think that requires actually an effort from us to understand why people behave differently on those times.
And what about in Ghana?
Well, if you go to any of our facilities, you will find that there's this big signpost saying, we provide 24/7 services. And it's not feasible. Because, for example, in a district hospital, there might be only one doctor there. That doctor cannot work 24/7. I mean, he'll burn out. With the lower levels, such as the CHIPS compound, that was why the idea came in that they should increase the number of personnel over there so that at least somebody might be available at night. And incidentally, most of the problems with children particularly happen at night, if you've noticed. It's usually at night that you notice the child is either very hot or shivering or has convulsed, and then you need to find care. But where are you going for that care? The health service complains about lack of a critical mass, but I believe that is more of a maldistribution of the mass that we have. It's not the numbers as they claim. So yes, it can be provided at certain levels, but I don't think that we can do it full coverage, no.
Okay. I think there's a question.
Hello, good afternoon. Thank you very much for your presentation. My name is Jiling. I'm a PhD candidate from the University of Lisbon. I'd like to maybe elaborate a little bit on the type 2 diabetes in Mexico City, the case that you presented. So one of my memories in Mexico was about a kid, a very small kid, walking along the highway with a very huge, like 2.5 liter Coca-Cola. So I think, and Mexico is like the biggest Coca-Cola consumption country. And the dietary habits a lot formed during childhood. And I think it's a great cause along the way later, in some of them developed into having diabetes. So my question would be, the health service in collaboration with the government, could there be any possibility of working closer to, let's say, with the food administration to try to impose stricter rules on these fast food, these unhealthy food production, so that we could prevent this type of diseases in an earlier stage? Thank you.
Yes, definitely. I think it's a very good question, and definitely. You're right about Coca-Cola in Mexico City. The infrastructure around Mexico City is being funded by Coca-Cola company, as far as I know. Coca-Cola is cheaper than water in Mexico City, and by the way, water is also supplied by Coca-Cola. So that's a vicious circle there, obviously, especially if you're not having enough money for the day. I mean, and if you're trying to optimize your carbohydrate, then cheap Coca-Cola is probably your best option. I'm not saying that it's the most healthy option. Definitely. The researcher we're working with in Mexico City, Dr. Simon Baquera from the National Institute of Public Health, he's also one of the champions behind the soda tax that has recently been introduced in Mexico. I think he's one of the most courageous guys that I've worked with in my career. He is receiving lots of threats on his life and on his family life for this fight against, always from anonymous people, but he gets them regularly. There's recently been an article about him in one of the big international newspapers. And it is like that for anybody who is trying to fight the soda industry. So definitely there needs to be work with, and that's also why I said that a fifth action arena could be food systems, because there are no easy answers here, and we have to understand how food systems are influencing health and public health. And there are probably a lot more people, even in this room, that are much more wise than I am. But it's an area where we have to go in and with this program to see if it can support the fight against diabetes in cities to prevent even more people getting this disease.
Pedro.
Sorry, can I jump in also on this one? Just call attention to one curious thing that's happening now in Portugal. We had a couple of years ago one of those documents that tries to reflect on a new vision for health systems and one of the things was everyone has to take his own part on the process. And from that they created a thing that's called Diabetes Challenge, which is to try to have interventions in populations at risk, different parts, and go for the education, including nutrition, as mentioned. But one of the things that's very difficult is where to stop short of the individual freedom of each of us choose what he eats without everyone telling you what you should and should not do. And I think that's one of the major challenges in these issues of putting stricter rules, in the sense that they are too strict, they are invading your privacy, and they're actually going to react against them and not comply with the ideas. And so what is the what is the midterm that will lead education to people? I don't really need education. Lead information to people and lead them to internalize that in a way that's helpful. Diabetes is probably one of the areas where you can do this the best way. It's amazing the work that has been done on nutrition and diabetes related. And the question is how to convince people to do it without showing that we are telling them to rule their own lives. I think that's the basic. The line is seen, right?
It's spot on, and we've seen it in many of the places that we've been working, that there is this questioning of where does the line go? I mean, should we interfere? And I think one of the issues, and we've seen it in all of the places we've been doing research so far, is one of the findings is that there is a lack of trust in authorities. No matter if it's the public sector, it's a healthcare sector, or it's the insurance companies and so on, there's a lack of trust. So how do you go out without preaching, without interfering in people's private lives? And I mean, these peer support programs we are running is one of the ways to get around it, because people tend to, and that's a fact of this world. We see it in the trust parameters. People, they trust people like me. Not me, but like themselves. And authorities, they are going down and down in the trust barometer reports that we see annually. So if we want to get to the heart and to the core of people, we also need to maybe to use peers more. And I think that is the way forward.
I think that's an excellent place to end this session. 3 fantastic and thought-provoking presentations. Can I ask the audience to give our speakers one more round of applause?